Can you hear me well? I can't hear you. Why? Let me see.
Yes.
Okay, I can hear you now very well. Good.
We're just waiting for people to join. It's 1 minute to 6. We have 31 participants already joined. However, we have well over 100 registered. So if you could just bear with us, and then we will start. I'm just going to mute everybody if that's okay, and then I'll unmute yourself, Samer and Prof. So it's just 6 o'clock. I'm going to say hi to everybody that's joining. We do have quite a few people registered who would like to join, who are just asking me to hang on. So bear with, and then I'll formally introduce Mr. Hamada, and Mr. Hamada will introduce Prof. Shetty. We are going to try and keep to time tonight, so we will start in just 1 minute at 2 minutes past 6. So I'm just going to do a little bit of housekeeping before I make an introduction of Mr. Hamada. I'd like to say welcome to everybody who is joining tonight's webinar. It's the first OSI webinar that has one CPD point attached to it. That's 1 point for 1 hour. So that's fantastic news. And we've got a great program ahead of us. We're very honoured to have our panel of Samer and Rohit tonight. It's a lot later in India than it is here. So I'm going to make a formal welcome and thank everybody for joining, and then I will hand over to Samer. You probably know Samer Hamada very well by now, particularly if you've joined the last few OSI webinars. He's a highly trained and experienced corneal surgeon with 18 years of experience in ophthalmology, both in the UK and internationally. He's completed 3 cornea and anterior segment fellowships, one of which when I was the service manager at Queen Victoria Hospital in East Grinstead, all those years ago. He's also completed a fellowship in paediatric ophthalmology at Great Ormond Street for Children in London. Mr. Hamada devotes a lot of time to developing new innovations for managing patients with corneal and ocular surface diseases. And he has a special interest in managing corneal problems in children, including corneal transplantation for babies born with congenital eye diseases. I know from my own experience how Mr. Hamada cares and really looks after his patients. And it's great that he's so respected and liked by not just the patients he treats, but the colleagues he works with. He wasn't expecting this intro tonight, but I thought I'd change it. I didn't want to repeat it after the last few weeks. But he's known for his professionalism, his expertise, and his kindness, and I'm honoured to work with him. So on that note, Samer, you're unmuted, and I'm handing over to you.
Oh yeah, thank you so much. I definitely didn't expect this introduction, so I really thank you so much.
We can't hear you, Samer.
Can you hear me now? Can you hear me now?
No.
Can you hear me now? Okay, let's see.
Okay.
Can you hear me now?
I can hear you.
Yeah, you're good.
Yeah, okay, good. Right. I was saying, Jel, thank you so much. I wasn't expecting this nice introduction. Thank you. Thank you for reminding me of a good days. It's amazing. Thanks a lot. Well, today is about a bit diving deep in a topic more than just talking on the surface. And it's really, really great pleasure to welcome Professor Rohit Shetty. I mean, he doesn't need introduction. He's a very well-known figure in the world of cornea ocular surface. But I thought I would like to give a couple of words about Professor Rohit Shetty. So he's a really consultant corneal refractive surgery. He's a vice chairman of Narayana Nethralaya in Bangalore. He's a clinical translational scientist. And he basically, as I said, he's a clinical scientist and with very keen interest in keratoconus, ectatic corneal diseases. He's practiced high volume refractory for a long time, I think at least 14, 15 years. He's a chief mentor of dual academic program at Narayana Netherlands Eye Institute in Bangalore. He's very well published, had done more than 200 publications, peer-reviewed journals. He edited so many. He has a long list of work, but he shine a lot in pain management after PRK, influencing of stromal molecular markers on the corneal ectasia, risk scoring system, which he discussed, and to predict ectasia after refractive surgery. And I think a lot of the work that I'm really interested, what he done is working on a dry eye. It was really remarkable looking at the molecular level to understand what's going on and why patients behave differently to maybe the same treatment and why the disease doesn't manifest in the same way in all the patients. And basically he showed us things, why it works and how it works, but also showed us things that we don't know and why we should know. So really great pleasure to welcome you, Rohit. I think it's, we've been discussing about this topic a little bit a while ago. And I think we had a chat early in Amsterdam, I think, when, was it Zurich, I think, we talked about the dry eye disease and why some patients don't respond the same way and what's the difference. And then you start telling me, digging deep in the surface thing about the cytokines and a lot of discussion on a molecular level. So that was very great insight into the disease. And I thought I would like really to share your thoughts with all the audience in the UK and worldwide. So I don't want to talk too much. I could spend half an hour introducing you. I would like to listen to you and learn from you, as many of my colleagues are joining the chat today. So without further delay, I would like you to start, if you don't mind, and please.
Thank you, Samer. And let me just start with my slides. Is the slides clearly seen? Are we clearly seen here?
Yep, we can hear you well.
Thank you. And I think I thank you, Samer, for a great introduction, and also your team, Jill, and your team from OSI for giving me this opportunity to share something which has been very dear to me. I come from Bangalore, and we are just coming out of lockdown now. So hoping that we learn something during this COVID time, which will make us better human beings. You know, that's what I always pray. These are my financial disclosures. I'm sure that this is not going to affect in my in my talks today. This very interesting cartoon I found a few years back about how lockdown has completely changed us. I'm sure you're also going through the same phase where all of us are trying to gather something different when we come out of this phase. Today's talk is not about giving my perspective. Today's talk is all about finding different avenues, different pathways for problems which has bothered us for a long time. So what I'm going to do is I'm going to talk about modern understanding of ocular surface disease, a new perspective. I have tried to avoid what has already been discussed, and I'm sure all of you are better versed than me. So I will try to concentrate on my work so that it's more easy for discussion. In the beginning, before we started this to go live, I did discuss that if anybody has a question or any opinion, you can always stop me wherever you want. I'm free to ask questions, answer questions and take it forward. And this is something which all of us know, the way the current treatment modalities are. I'm not going to dwell into this. We all know what treatments for the early, late, and severe cases of dry eye. But what Dr. Samer said is all about, today's talk is all about finding why patients don't respond to the conventional treatment. I'm sure all of you have read this story, or you must have heard this from somewhere. The 6 blind men and an elephant. I mean, it's such a famous and inspiration story today. Everybody touches one part of it and makes a diagnosis of the disease. I think this is where dry eye is today. I'm sure exactly the same thing is happening to COVID. Everybody picks up one part of it and says that, okay, this is what is causing the change. This is why it is not responding. We are not looking at the elephant. We are looking just at one part of an elephant. Because of this is not going to change anything to do with our treatment, because old ways will never open new doors. So let me just try to, I'm not saying that we have unraveled the mysteries of all that what we're going to talk today. All I'm saying is that there are new doors and we just have to keep knocking at more doors so that we finally get some answers. I want to look at the elephant as a whole. I don't want to look at elephant as a part, I mean, based on the story. So I bring in a cell biology, the imaging, translation work. I think a lot of stuff comes from the psychological behavior of the patient, how he or she behaves, and a lot to do with the genomic profiling. So what my talk today is going to link all of them and see how we are trying to find the answer, which is always going to bother us. So I divided my talk into biomarkers. We look at the corneal nerves, the bespoke approach to the pharmaceutical drugs today, and how COVID is affecting the ocular surface, and what can you do to prevent this, both for the patient as well as yourself as the doctor who is going to treat. So let's start with biomarkers. So let's start with tears. So when you talk about a biomarker, the biomarker is something which you study from a tissue or a cell or a fluid, and these fluids or cells gives you an answer to the question you're asking. So biomarker, to understand a biomarker, you have to ask a question. And only if you have a question, the biomarker is going to be useful. So what is the first biomarker? The first cardinal rule is the Schirmer strip which you store. So 15 to 16 years back, we felt that this is where the whole answers, this is where the answers is going to be. So what did we do? We started preserving everything which we discard in your practice. Your epithelium, your trabecular meshworks, the vitreous, the aqueous, lenticules, all the Schirmer strips. And where do you preserve them? Do you preserve in a biobank? And this is a -80-degree cryopreserved one. We have a huge one. At this point of time, we are one of the world's largest biorepository of all the ocular surface, ocular related samples. The question usually people ask is, are you allowed to do it? You are allowed to do it if you have a proper consent. Even if when the patient says that I need, even if I had to take a Schirmer strip on my patient, I ask them that can I preserve this for the future? And if the patient answers this consent form, then we preserve it and it goes to one of them over here. So this is how we've been doing, and this is what we've been working on. Okay, now you have loads and loads of them loaded all over. So imagine I want to go back and work, for example, the patient X, I had stored the sample over here. And this patient X comes back to me after maybe 4 years or 3 years and comes back with some problem. So I can always go back and check this X and figure out what was the problem. It's like exhuming a mummy. And once you take it out, you can know serially, longitudinally, what is happening to the tears. Or I want to pull in a case. I want to pull all the cases of dry eye disease which went into an ectasia. So I can go back to this box and figure out who all the dry eye samples I have and take it out. So this is what I call it as the biomarkers. And this is what is necessary for a good biomarker project. You have to preserve them. So if you have a tissue, if you have a tears, what do you do with them? There's a hell a lot of stuff you can do. You can look at proteins, you can look at molecular targets. I mean, virtually the scientists will load you with things which you can do. And this is a gold mine. And if you don't have it, that's what I said. If you don't have it, you can never have a biomarkers. If you preserve it, then you flow charts. I mean, this is one of the flow charts I've given. There are many, many of them. So what do you get out of it? Now comes the clinician. This I'm wearing a clinician hat now. So far I was wearing a researcher hat. When a clinician comes to you and he comes and tells me that I have pain, but we as clinician examined and there was nothing I could find to see that he's suffering from something unusual. Then that's when you call the tear film analysis. Then you have a lot of molecular factors out here. That means you have a pro-nociceptive and anti-nociceptive. Very simple thing. Pro means it makes you feel hurt. It makes you feel irritated. It makes you feel chronically unhappy with your eye. This could happen after surgery, or this could happen without surgery. And anti actually blocks this. So that means that there should be always a very beautiful balance between an anti and a pro. When the balance tilts, look at this. This is blue, green, which is low, which is good. This green is up, which is good because there is a balance. Now look at this. Everything is completely changed. So what happens is, where did I find all this from? They all were found from the tears, which we preserve. So what happens is, if I look at hundreds of patients who come to me where the drugs don't work, Dr. Samer gave a very nice description of what my talk is. He said that trying to find sometimes answers to something which we don't know. So when we start looking at these, then we know, oh, this is why it doesn't work, because a lot of them don't have drugs so far. You can use steroids, but they don't really have a specific targeted drug. So when you don't have a targeted drug, you're using drugs which just doesn't block them. So what do we do in the future is tell the pharmaceutical industry that I have a cohort of patients who are coming with these kind of molecules and we need a new drug for it. And this is how drugs are developed. So from a clinician point of view, I will not tell my patient as patient who is psychologically upset. That's why the patient is complaining of pain. When you look at this chart, it makes me feel that the patient has something, but we are not able to understand it because there is a huge difference in what we can see and what we don't see. And this is what we don't see. And this is what is a problem. We did publish recently, and I go into this publication about a huge bunch of tear proteomics. This paper took me 6 years to publish. We had to collect the tears. Lots of tears were collected of a lot of patients, and we also found a correlation to vitamin D. Very interestingly, vitamin D is becoming a very, very prominent factor even in your COVID. People who have a good vitamin D are known to have a less severe outcome in the disease of COVID compared to with very low vitamin D. That's very low vitamin D. That means that vitamin D is an immunomodulator. It is exactly what it's doing. This paper was published much before this. It's exactly what it's doing. It's working like an immunomodulator on the ocular surface. There are so many other things apart from dry eye which we are looking at. I worked on doing VEGF screening on ROP babies. And we found that it's very interesting. You know, you can look at the VEGF and that correlated with the severity of ROP. That means that this could be a potential biomarker for ROPs. Very good pickup. And this is going to be, we are in the manuscript stage. We're going to publish this. It's come out beautifully. The severity of your ROP correlates well with the changes in your VEGF. And that's a very beautiful way, because, it could be a non-invasive technique. You can see that this whole graphs just is self-explanatory. We published this work, dopamine levels in human tears. Why is dopamine important? Because dopamine is linked to myopia progression in children. That means dopamine is kind of a protectant, if you have a good amount of dopamine, then your ability to have a progressive myopia, somehow it controls the scleral fibroblasts, or there's some mechanism to it. So what is interesting here is, if you have a biomarker, if you preserve them or if you work on them, the most important thing is you have to question. Without question, you can never have biomarkers. So if you ask relevant questions, then you will always find relevant biomarkers. This is what my take is, that you have to keep asking questions. So biomarkers ranges from finding unknown problems of dry eye, to figuring out the myopia progression or ROP progression. All this could be a various factors in the process of biomarkers. The second biomarker is the corneal epithelial cells. So before I go into the epithelium, this is a work which we do. This is human epithelial cells, but it's an in vitro, it's not in vivo, it's not on the patients. And such beautiful images. This is a holotomography. You take the epithelial cells and you can image, it's like an OCT. You can actually see every cell organelles here. And these are all human cells. You can see that they're mitochondria, Golgi bodies, and how each cells are connecting and how the transport happens between the cells. And this is a healthy cell without stress. No dry eye. This is exactly how a cell would look if we have a mechanism to image that. But if there is inflammation, what happens? There is a lot of stress, a lot of cells. You can't even see any of those mitochondrial, and you can see this. And stretching filaments. They're trying. Each cell is struggling to send food. It's like how when you have a lockdown, how people are trying to help to send food. You can see that each cell is running over the other, and there is no coordination. There's no. It's in chaotic music, chaotic dance music out compared to what you see here. So this is exactly what happens when you are in a dry eye status. And you create an hyperosmolar status. This is what happens. Absolutely, you don't see any organelles at all. They're dying. But when you start using drops, this is one of the newer molecules which we're using. And we want, because this molecule is not only a lubricant, but also helps to regenerate those cells. They call the autophagy inducers. Autophagy is a housekeeping mechanism of a cell, and it tries to induce it. And you can see that the same thing is completely different. Now you can see that cell organelles here. There is a transport here compared to this one where absolutely it is dead. So this is exactly what happens when your drug is working, when it starts working. We also looked at epithelium as a biomarker for PRK haze. What we did was we used to take a lot of this epithelium, we used to preserve them. So when I do a PRK, it's a 90% chance that PRK haze is not related to your lasers. If I ask refractive surgeons, they would blame that 100% of the time. They say, okay, I didn't use mitomycin, I didn't use my laser properly, or I use more of laser. But let me tell you, your PRK haze could be driven by the genes which you already have in you. And whether you treat a -1 or a -10, this person will develop a haze. And this is what the paper says, that the haze forming mechanism is already existing in your epithelium. You are genetically predisposed. How did you get it? Because we did not discard the epithelium. We preserved the epithelium, and patient developed haze after a year. I told you in the beginning, we went back to our mummified biobank and we took out those epithelium, of all the patients who developed haze and compared with all the people who did not develop haze. And this is the beauty of biomarker, because you can virtually go back and pick up a lot of things which otherwise would have gone. If I had discarded the epithelium, and if these patients come to me with haze, I would probably never ever think that these patients could have a genes, uh, induced genes which could probably create haze. You can see that the wound healing factors are completely different here. This is something very exciting field, because we are trying to bring in a concept that the genes and epigenetics could be a factor in the wound healing post-refractive surgery. The third part of it, biomarker, is the nutrition. How does nutrition really play help? And I'm not going too deep into the other nutrition factors, because vitamin D is my favorite, because at this point of time, it is leading the roost, because people are talking about it, and vitamin D is heavily linked to a lot of immunological disease. And we have done a lot of work, especially, changes in the osmolality would change the vitamin D receptors on the cornea. There are epithelial cells have a vitamin D receptor, the corneal epithelial cells. So that means if God has put a vitamin D receptor, that means it has to do a function. And I have summarized here what all it can do. It is an endogenous anti-inflammatory regulator, which is from the published work. And it brings in vitamin D receptors are necessary for it to act. And what I'm trying to say is the corneal epithelial cells should have the receptors here, and only then it starts working. That means me and Samer may have a very normal vitamin D, but if a receptor is not functional on the epithelial cell, then the patient can have all the signs of inflammation, and you will never get better. So vitamin D has a very important role in ocular surface disease. This is one of the major work which we have been able to, which we are able to prove over the last few years now, with close to 15 or 16 papers. And these are some of our work where we are looking at vitamin D and inflammation. When you have an inflammation, the vitamin D receptor shuts down. When there's an osmolality, the vitamin D receptor shuts down. That means what we are trying to say is vitamin D being normal or abnormal is not the only thing which is important. You need to have a vitamin D receptors probably on your epithelial cells. If the epithelial cells do not have it, then you are in trouble, because vitamin D, according to us, plays a very important role in being an endogenous modulator of ocular surface immune cells. So it has a huge role in immune cells. So it is very important you keep your level there. And these are some of those vitamin D receptors work which we have done. In dry eye, you don't see them staining, and in controls who have a normal, it's good. So it just shows that how beautifully vitamin D is necessary in our thing. And you can see that as the osmolality increases, the vitamin D receptors reduces. So that means having a hyperosmolality status not only brings in inflammation, it also shuts down the endogenous regulator of inflammation, that's the vitamin D receptors. So these are all extremely new findings. How does it help a clinician? As you and me as clinicians, we should look at tomorrow trying to see if they can help in a vitamin D drops, which could be on a local ocular surface. And this could probably kickstart the vitamin D receptors. So what is important here from this is, like I already mentioned, that you may have a patient with a low vitamin D and no symptoms, or you may have a patient who may have a high vitamin D and more symptoms. It's all related to how your receptors are. It's not just the vitamin D at this point of time. So it's very important that we keep this in mind. So after this, all these areas of the nutrition, the epithelium, and the biomarkers, let me go deeper into something called neuropathic pain. And all of us, I'm sure all of us have these problems, and this is something very common. One of the things which comes from this Annette Gala paper is that, people who have more of neuropathic pain are otherwise also more symptomatic. They are always having pain all over the body. So we started working. I'm just summarizing 13, 14 years of my work on the confocal microscope, the beautiful corneal nerves, how, the way it is. What is very interesting about these nerves are how well socially distanced they are. And when they're healthy, they don't come very close. They're not overlapping. They're very happy. And look at this. This is a typical pre-COVID times. They are all closely bunched together. They connect to each other. And what's interesting is these cells. I spent a lot of time, close to a decade, working on them. They're dendritic cells. So when I see a confocal microscopy of a patient, I know what his complaints are. His complaints are pain, non-resolving problems. Whatever you treat them with just doesn't go off because there is inflammation. And inflammation, you give them steroid, they don't just go off because these are chronic cells. They're the chronic signs of inflammation. There's something chronicity in this. And we figured out that a lot of them were related to low vitamin D, low immunity, and all these factors. The second thing is we found was how close they are to the nerves. When they're very close onto the nerves, so for example, look at them, they are all close to the nerves. When you are very close to the nerve, they irritate more. So that means what my topic is what you don't see. See, many times you do a confocal microscopy and you say, okay, cornea is normal, there's some dendritic cells, but everything is very important. How close are these cells? See, look at this, they're sitting on the nerves. They're sitting on the nerves. Some of them are just on this. So all this plays a very important role in how a patient actually responds to your treatment. And I've shown about this that dendritic cells is extremely having extremely symptomatic dendritic cells even in a state of in your vitamin D and other deficiencies. You can see that how many cells are there, it is abnormal compared to this, it is normal. So it has a huge role in your health of your eye. If you have a confocal and if you are referring to some place, confocal microscopy really helps to see what we don't see. And this connects to all these molecules, what I just mentioned, directly connects to how the health of the corneal nerves, and they are the ones which makes you high OSTI, and they're the ones who makes you very irritated. This is interesting, we see sometimes these cells, they are microneuromas. And like how you have a nerve, they could be related to some microtraumas there, but like how you have changes on your nerve, they are all microneuromas. These could have come with a lot of pain. And these could be a factor. Sometimes, whatever you do, they just don't go away. The pain does not go away. So it is very important before you label this patient, send them off for a psychiatry or treat them with an antipsychotic or one of the gabapentin-based drugs, get a confocal microscopy done. It will tell you whether the patient has a local issue or a systemic issue. If your patient has all these factors like this, this is all local issues. But if you don't have anything and if the patient has perfect normal eyes like this and still has pain, then the problem may not be here. It is more of a central issue. So what I'm trying to say is there is a huge role for confocal microscopy in our practice, especially the referral-based practice. And this is one of my patients where he had a chronic pain suffering from close to 6 or 7 years. And he had a you can see that everybody labeled him as a psychotic patient and he was referred to many places. He came to me and you can see that this patient has a beautiful, nice microneuroma. But what was very interesting, this is the first case report of this kind. The same place when I did the OCT, I can see that there is a Bauman's break. So the microneuroma was somewhere here with a Bauman's break and which was completely exposed to the noxious stimuli. I mean, isn't it interesting how much we don't see and how many times we try to make a diagnosis? So if you really look at this particular case, this is exactly the same pace as here, maybe. I mean, you cannot match an OCT and a confocal together, but what I believe is he had many microneuromas. So I had to keep him on a very, very long-term steroids with cyclosporin. I did a LipiFlow for him, reduce the inflammation here. Once the inflammation reduces here, what goes in also gets reduced. So you have to always reduce what goes in, because if this is an exposed naked nerve endings here, if your cytokines are not bothering it, then probably you're safer. So you cannot do anything to microneuroma, you cannot ablate it, but you can block it, what is going in. So that's very important in this. And what I'm trying to emphasize here is confocal microscopy, reading, understanding, and making a judgment is very, very important here. And this is exactly what I said about neuroma. And this is what I made up for this proposed neuropathic brain, that you had to look for. Please look for your Bowman's layer. A good OCT can pick up, because if the Bowman's layer is thinned out or it's having breaks, then your nerves can get exposed. The inflammation can go in through those breaks and starts irritating them. And this is what we wrote in that paper. Coming to how does nerve have an impact on the refractive surgery? This is from a rabbit experiment. About what I'm saying is a rabbit. This is from a humans. How a wound healing happens. Like, for example, if I scratch my eyes and I have a small epithelial defect, how does it happen? Very interesting thing happens is the first sign of inflammation is always pro-inflammatory. That means without inflammation, you cannot get healed. So it is the most, when I say inflammation, many times we say, oh, inflammation is bad. I don't think inflammation is bad. Inflammation is always the best thing. It's the angelic thing you can get. The second thing is pro-fibrotic. That means it brings in all the fibrotic cells to make it better. The third one is you can see that is the healing phase, where wound remodeling happens and you get healed. So this is how a wound healing happens. But if your patient has more of this, for example, he's a contact lens wearer, he's got a very high OSDI to begin with, and you do a surgery on him. Now what happens? You end up not having the second wave. For example, the patient is high OSDI, he's a contact lens wearer, a lot of dendritic cells. What's very interesting is I call OSDI score as a poor man's confocal microscopy, because if you have a high OSDI, it means the cornea, the nerves are also bad, and so is your dendritic cells. So what happens is you don't get the second wave, you just get one wave. And this is what is very important, because if this does not come down, what happens here is haze and pain. This is what happens. So if you don't have this wave like this and this, you will end up in haze and pain, which is the most common. For example, the same patient I operated, what happened? His nerves, you can see how bad they are. There's completely chaos there. So this patient came to me because he was not tolerating contact lenses. There was a lot of pain and he wanted refractive surgery. And at that point of time, okay, you want to do a surgery, you just go ahead and do it. And that's what happens. And now you realize that he had chronic pain afterwards, because I did not probably at that point of time understand this. For example, this is what happens. If you are doing a PRK, this was a pain patient. This is a pain. And if I'm doing a PRK, what happens? Exactly, if there is wound healing is bad, you end up in haze. Because these factors here, which is pre-existing before surgery, makes your cornea go into a myofibroblast, wound healing is bad. So what I'm trying to say is, we can have a discussion on that later, is everything you do on a pre-operative level has a huge impact. What can I do as a clinician? It's not possible to get a confocal microscopy for everybody. Like I said, the OSDI is a poor man's confocal, because it tells you if it's a high OSDI, it means that this part is high. Remember that if this part is high, then you have to bring it down and then get the third wave. Remember the 3 waves of the healing. The 3 waves of healing has to be there for you to get asymptomatic patient and a perfectly good, no haze corneas. This is why we get haze. So what I'm trying to say is, based on my work, haze is not just driven by your laser or mitomycin. Haze is driven by this. And remember, this is the major factor. And I put a lot of emphasis on this. And you reduce the inflammation, the nerves get better. If you look at these nerves, After I reduce the inflammation, see how it gets better, and then you do your surgery, your 3 waves are perfect. So pro-healing phase is very, because all you're doing is controlling this. And if you can control this in refractive surgery, you can do anything. That's the most important thing. And does it hold good in the patient? You can see that patient 1, no pre-op inflammation, and patient 2 has got pre-op inflammation. So what happens is the nerves are healthy, here not healthy. So we did the surgery on LASIK, and these patients are the ones who will end up in complication. I have published this work. Poor nerves can lead to ectasias. We found that all the patients who had ectasias, post-LASIK ectasias, had poor nerves. That means that there was something wrong in the healing. The nerves maintain hemostasis. The nerves maintain hemostasis of epithelium. The nerves maintain the structure of your cornea. The nerves are necessary. If you don't have a healthy nerves, you will never have a healthy cornea. And that is what leads to all these changes. And these are some of those papers. And we can see that there's one interesting paper I did on this is again one of the world's first report of having a LOX gene defect in smile ectasia. I'll tell you what was interesting of this. This patient had a smile done 4 years back, comes back to me with a smile ectasia. At that point of time, I go back, the patient was completely normal topography. There was not a single problem in the topography. Now, this is where the challenge comes. Because for me, for us, all of us clinicians, we just look at what is there. And if you don't see, that means it does not exist. But you remember what I said in the beginning, I never throw anything where the patient, of anything what comes out of the patient, if she agrees. I had preserved her lenticule 4 years back. So when I went back and did an analysis of genetic analysis of the lenticule, we found that she had a genetic defect of lysyl oxidase, and she had a defect even before I did the surgery. My surgery was just a trigger. Now, how does all this work? So what we did was we did some experiment. How does your dry and ocular surface induces changes in your collagen? Again, this was done in the lab, and we created the human epithelial cells. And what we did was we created an inflammation on the corneal surface, which was the corneal collagen and epithelial cells. And you can see that as the inflammation increased, which is driven by your MMP9, your collagen started reducing. So that means that your inflammation becomes more, your collagen starts becoming less. So what does it mean? That keratoconus is inflammation driven. So if you have a patient who is in chronic inflammation all the time, and if you are not controlling the inflammation, the patient's collagen by logs and collagen all starts coming down. This is very, very important, because if it comes down, then your cornea starts becoming ectatic. So what happens is very important that if you are able to block them here, if you can block them here, probably you can increase the type of collagen out here. So this is very important, because inflammation can drive not just changes on your nerve and ocular surface, it has an impact on your collagen and your lysyl oxidase. So that means patients who develop ectasia post LASIK surgery are also the ones who may have a lot of inflammation in their eyes. And we did a study that patients having more dryness and more eye rubbing, dryness leads to eye rubbing. I don't believe that eye rubbing is the only cause of ectasia. So these could all change and create problems. We also work a lot on optics of tear film. There are a lot of new methods now. We look at the point spread function of your tear film, no financial interest in them. And you can see that how the tear film changes between blinks. Very useful thing, because this patient was referred to me because he was having a multifocal glare. That means that multifocal lens is creating glare. Now tell me, the patient's multifocal is perfect. He's not, patient been asked to go back home because he needs neuroadaptation. It is just that his tear film is changing so much between that 4 seconds that he's complaining of glare, compared to this one where this tear film is perfect and there's no glare. So this is again what we don't see. My talk is all about what we don't see. And tear film is a very, very important optics in our whole optical system, and we should not forget this at all. There are a lot of bespoke management. Like I said, each and every single molecule can be targeted. We as clinicians should be pushing for the companies to come out with this. And we are coming out with if this lockdown was not there, I would have shown you the real time small testing device. Now everybody in this world is going to COVID testing, but this is something similar which we are trying to do, ELISA based kits, where we can take the tear film and we can do a point of care diagnostic in your room, in your clinic, and it will tell you which molecules are the ones which are changing. And this is how I'll just small video, this is how it look, and these are all the plates on the plates which we do. And we have some antibodies to that, and this can be done in your clinics, and it will tell you all the molecules which I described. We will know what is happening, and we can see that this is how, as a clinicians, many times we don't see. This is how each molecules can be blocked. For example, if you are working on liftigrast, it works on these molecules. For example, sometimes you say, oh, liftigrast does not work on my patient. That means he may be having this. Or somebody may say that, okay, my patient is complaining of pain. I use cyclosporin, but it's not working because he may have this. So what is important here is it's like a diabetic patient getting diabetic treatment without looking at his sugars. Ocular surface disease today is like diabetes patient getting it without giving an insulin, without looking at what his sugars are. This image on your screen tells you that we need a customized targeted approach. We have LipiFlows, and LipiFlow exactly, we have worked on the tear films. We look at all the molecules. We know that it's working because the molecules are getting better, and this is exactly where it works, which molecules it works. Even the iLight also works on the particular molecule. So each one has its own way of targeted thing. And when the molecules get better, all this gets changed. So this is how it works. Finally, last few slides on COVID. This is the work done by our team. We are working on epithelial cells in COVID. And you can see that this is exactly what happens. The corneal epithelial cells has receptors for it to enter. So that is the most scary part, which we have to understand. The ACE2 inhibitors are there. All that the COVID needs for it to enter into nasal mucosal cells or the oral cells, we have it on the corneal epithelial cells. So I don't see a reason why it's not going to catch on to it. I mean, I'm sure it will be there. Just the time it will tell us. This is done by one of my lab scientists, Dr. Archana, and she's drawn this whole picture, what it works. So we worked on some hypothetical based prophylaxis for healthcare workers, because now we are all going back to work. What should I take on myself, apart from chloroquine tablets and other things, if I had to go back to work? Disclaimer is just an hypothesis like everything else in COVID. So what we did was, there was a lot of molecules which is high risk for the doctors, and this is based on the paper. One of the molecules which we feel that it has a huge potential as a prophylaxis for the healthcare worker is a trehalose. We also in India have chloroquine drops, which we can use. Trehalose works on multiple things. You can see that these are the areas of work. I think in UK it's sold as Teo tears or Teo drops. Some company, Tia tears is the one which makes it. And we published some work on how it works, not on COVID, but on the dry eye. This is on the chloroquine, both the papers. And this is where it acts. This blue is trehalose, green is chloroquine on the epithelial cells. You can see that they block the uptake. This is very interesting how they block the uptake in the cell culture cell model and degrades the endozymes. And trehalose induces the interferons, which is an antiviral, which is exactly what we need in COVID. So what I'm trying to say is we had to test it further and see, but we do have a molecule which is a lubricant in your own place, which can be used when you're probably going to work. This could be a protectant. This is a very early work, but I just want to tell because it may not cause any harm because it's a lubricant, but this is the pathway in it, it's working. And I'm writing a paper on this. I'll share with you once it's done. And this is what we do for the COVID. These are the last slide of mine. If you're a non-allergic patient, you don't need to worry. But if an allergic patient, I encourage my doctors when you operate to use hypertonic saline because it makes your pH alkaline. And there's something very important. Take care of your vitamin D. It's very, very important because if your vitamin D is less than 10, there's a huge chance that one of us will get this disease when we are working in our OT or with the patient. If you have a lot of OT to do and you're spending a lot of time in close proximity to the patient, in India we have chloroquine drops, but if you don't have, trehalose is definitely an option, and work out on your body and other factors, which is very important. I just gave a brief insight at what is really changing, and it's the inflammation which is driving everything, including this virus. If you knock it off, I think there is a lot of ways in making your eyes better. This is my entire team of researchers. I work with a very big team of people working from all zones. I said I don't look at an elephant as a 6 blind men. I look at an elephant as a whole. So I need all these people to make me see the elephant as a whole, so I can answer a question from multiple aspects rather than answering from one place. I end my talk, and I pray and hope that all of you are safe, and we one day, all of us can meet in a physical format of the meeting, which I enjoy the most. Thank you, Samer, and thank you, the team, for this opportunity.
Thank you, Rohit. I have to say, this is amazing talk. You covered so many areas very elegantly, very nicely. And I can't tell you, my messages keep coming, say, thank you for hosting Rohit. He's an amazing speaker. What a knowledge, what's amazing information we got today. Well, right, I have a few questions to go through, if it's okay. And I'll try to be more clinician right here, more than scientist. You showed us how the science really enrich our knowledge and help us to diagnose number one and treat number two. And you touch on the inflammation in keratoconus. So you showed about the inflammation keratoconus, the role of corneal nerve, all that. So, and I'll start from where you ended about trehalose role in ocular surface inflammation. So let me ask you a clinical question. Now, a patient with the keratoconus, are you gonna give him trehalose drops to stop the inflammation, because we know the inflammation is contributed to keratoconus condition?
Trehalose may not block the inflammation if the inflammation is of a very high level. So what I would do is, if the patient has a lot of inflammation, I still give them I ask them for the eye rubbing, and I ask them for the signs of inflammation. If it's very high, then I would give a trial of cyclosporin drops. Because we have published this in IOVS 2015, I think, or 2014, where a small cohort of patients where we use a cyclosporin, it can stabilize your eyes if your patient is treated. I look for IgE in a lot of my younger patients, because more of my children suffer from IgE. And if the IgE is very high, more than 500, then I usually ask for immunologist's opinion, because most of these children are allergic to something which they don't know. I've had children having allergic to sweater wool, and the parents were making them wear sweater every day. I have children allergic to almonds, I have children allergic to multiple things. And if you don't get them checked, they will never get it better. And avoidance of them actually stop the progression in many patients. So, and if there is patients who has no allergy, and I just keeping him on an observation for 6 months for him to come back, rather than just ask him to come back of 6 months. At this point of time, I use trehalose because it works on, it works like an anti-inflammatory without actually having the side effects of an anti-inflammatory. It's just a lubricant.
Okay, good. So having been equipped with a lot of science, really, let's talk about your dry eye patients. So you have a patient coming to you with a dry eye. What's your basic diagnostics here?
One of the major diagnostics which I use on dry eye patient nowadays is a questionnaire, which we have online question. We also made it online so that the patient can fill the questionnaire, and it will tell you, it will triage him, like does he need a immediate, or he can come a little late, especially during this time. And once he comes in, I do the routine stuff of TBAT, Shermas, and all the patient. And being a scientist, I don't throw them. I told you we keep all of them. And most of my patients, if the patient has symptoms which is beyond the capacity of understanding through just the signs, because the signs are missing but the symptoms are more, then I use confocal microscopy a lot to find out if the patient is actually telling me the truth or is it something else. And 99% of the time, I have figured out that the patients have been referred from multiple places as saying that they are not telling the truth. There may be psychological problem, and confocal microscopy always picks up. You could pick up dendritic cells, you could pick up microneuromas, you could pick up multiple things. Once I see that there is some problem, then I start targeting them. And I get an evaluation of a vitamin D for a lot of my patients. And if there is a lot of pain without stain, basically if you have more of neuropathic pain, and I asked them about the history of diet, because now what is happening is being vegan is a very big thing. A lot of people suddenly become vegans overnight, and they suddenly suffer from a lot of vitamin B12 deficiency, which could lead to these changes. So dietary changes are very important today in today's practice. So once it's done, and then I start them on, most of my patients would need an anti-inflammatory drug. I give this based on OSDI, I triage them into, do I need to start them with steroids, with the cyclosporine, or just cyclosporine? If there's not much of symptoms, then only lubricant-based treatments. But most important thing is I look out for nutrition. I look out for the vitamins, especially vitamin D and B12, which according to me has a huge role in non-responding patients. If your patient is non-responding and you try getting it done and refer to a physician, and you will see how fast they would respond. It's a feel-good, it's not a vitamin, it's a feel-good hormone. When your mood is blue, a lot of people give vitamin D, it makes you better.
Okay, so you said vitamin D, you could have a normal values, but you still have a problem with your receptors, right? Epithelium receptors. So would you give it anyway in high doses?
If the vitamin D is less than, say, 20, the normal is 35. And in our country, even with so much of sunshine, we have 80% of our people are less of vitamin D because we are becoming more indoors. But if it's less, and if the patient has a lot of symptoms, if your physician can give him a bolus dose of intramuscular dose of vitamin D, they can titrate it. Too much will lead to renal stones. So physician can titrate it, and you will see that 99% of your patients will come back feeling that they're much better. And a lot of them come back and they're very happy with me, because along with the pain, they feel that the hair started growing better, the hair fall has reduced, skin has started glowing. So a lot of other collateral benefits are there.
So what's your strategy then treating the dry eye patient?
Like, if I usually ask all my patients if there's more of symptoms than the signs, then I go aggressively into finding the reason. If there are more of signs, then I treat the signs, because that is always there. Like if your TBUT is low, if you have a lid meibomian gland dropouts, then you have to start them on a steroids for 6 weeks. Then along with steroid, you start them on a cyclosporine and a lubricant. But the challenge is that part, I think we all know what to do, because everybody knows to treat it. But the challenge is those 20-25% of people where your signs are very less, the symptoms are more. So when your symptoms are more, then I go aggressive into finding the reason why the symptoms are more. And that's when I need to look for your nutrition, or I go refer, I have my confocal, but if you don't have it, then you can refer to somebody who has it, because you will get a lot of picture. For example, if you have a microneuromas, and these patients, then what I do is they need a very fast reduction of your your cytokines, then what I do is we even do a LipiFlow. We have a lot of patients going for LipiFlow because LipiFlow works in reducing your inflammation cytokines in your ocular surface. When your inflammation cytokine reduces, the load of cytokine reduces. So what happens is then your pain and other irritation comes down drastically. So we also use them for a lot of people with even with signs and without signs also.
Do you think the IPL work the same way like LipiFlow?
Absolutely.
Yeah.
We compared IPL and LipiFlow both. LipiFlow is little more for the patient. It gives a little warm feeling, and IPL. But I feel the molecular pathways. I studied a lot of molecular pathways. That means we took the tears before and after. We evaluated for 6 months. And we found that it reduces a lot of those factors which actually causes pain.
Amazing. That's very good. I have one more question. Then I think we have a question from the floor. Just what do you think then about because we're talking about this treatment path now, what do you think about the role of using serum eye drops, AMTs at early stage? I mean, personally, I'm advocating early intervention because I believe exactly what you think about the raw inflammation, and is to stop it at early stage at that peak, then you stop it things sequely. So I tend to be a bit more aggressive, let's say. I'm not talking about a simple case, but cases that are not responding to the conservative treatment, go straight with the serum eye drops and AMT. Would that approach, would you consider?
Yeah, I've done a lot of these patients. What I've done is I have tried. That's the reason, sometimes when you see what you want to see, then treatments becomes more logical. For example, if I ask for a confocal microscopy and I see a big microneuroma there, or I see a lot of dendritic there, I know it's inflammation, and I know a lot of drugs don't work. Then what you said is right. You use your serum, autologous serum, and you start using it. Autologous serum has a lot of neurotropic factors, which helps the nerve regeneration. I've treated many patients based on this. So the way I do it is you prove it that there is an existing problem. So it becomes you are mentally sure that you're going to treat it in a proper way. I completely agree with you on this.
Yeah, you privileged, and I think we're privileged in our unit. We have a confocal microscopy, but I don't think that's widely available to people to use it as on a daily practice. Okay, thank you so much so far. I think Jill got a few questions as well from the floor. Yeah.
I do, quite a lot actually, Prof. So I may have to send some by email, and they're quite varied from right at the beginning of your presentation. So I will try to get through them. I'd like to say thank you to participants for still hanging on. It is 7 o'clock. We're probably going to run till about 10 past, 7:15. So please feel free to stay with us. So Dr. Christine Purslow has asked to Prof. I'd like to ask him about the storage of samples over long periods. What temperature, and do you pool the samples?
At minus 80 degrees. We keep it at minus 80 degrees.
And do you pool them?
Yes, each patient has a small locket which has a name and his number. So if I take patient X after say 5 years, if I have to look back what he had, then 5 years back, I can take it out.
Okay, perfect. Thank you. Thank you, Chris, for that question. Dr. Shola Dada has asked, with pain post-laser, does the same apply in patients who have had LASIK where a flap is raised compared with PRK where the epithelium is removed, or is it intensely pain different?
I feel that the pain post-LASIK or PRK is all dependent on how he was before the surgery. So if you go back and look at your profiling of your patient, a simple OSDI scoring, which tells you how symptomatic he is. Many times we just write on a file that patient is not tolerating contact lenses, so we are going for a LASIK surgery. In fact, that's the biggest red flag, because that raises that flag that this patient has extremely inflamed eye. And these patients I usually give a month of mild steroids or cyclosporin to reduce the problem and then take them up. And these patients never heal properly on the corneal nerve. I did show in my presentation. So take care of his pre-op. You will be having a very good post-op.
Samer, do you have anything to add to that?
No, I agree actually what he said, because the graph you showed about the peak in inflammation before you end up with the all the dendritic activate cells activation, etc. So I think surgically, and that's what when we talk about, because actually that was a question from to you, is about how to prepare your patient before refractive surgery. And do you do anything special more than give them a bit of maybe omega-3 or some make sure they have no ocular surface inflammation and management of MGD, which I think a lot of us do it. Do you have any different ways to manage those patients before refractive surgery?
Like, you're asking me?
Yes.
Okay, sorry.
You.
So what I do is, like I said, when they come in, I just give them my scoring. I look at how bad the scoring is. Then I do the test. And if my scoring is bad and there are a lot of signs and their tear film is not of good quality, then I give them 4 to 6 weeks time before I take them up for any of these procedures, because whatever I do, these patients are never going to be happy. And explain to them that, sometimes if the symptoms are mild, then start them on a mild steroids with the drops, then give them a wash off time, a week, and then you do the procedure. And I personally feel that you need to really understand them before surgery to avoid problems post-operatively.
Yeah, I mean, I do a similar approach. I do those patients divide between mild, moderate, and severe. We do this dry assessment, and those mild will go for 6 weeks. All of them go for 6 weeks treatment, MGD management, etc. If they come back and they're still showing those really significant signs and symptoms, I will go to another 3 months where I use cyclosporin and be more aggressive on tackling inflammation. 3 months is still not down the line. I'll say, I'm not doing the refractive operation. Let's go to dry clinic. Maybe in future we'll consider that. And it's been working for me very well, avoiding those, as you said, patients where it might end up with the complication and troubles. Yeah.
And just to add one point now, that sometimes when the patient are a little bit of in a hurry, then I usually do a lippy flow, give them a week or 10 days time, because that drastically reduces your inflammation. And I've done the study between, by 10 days time, your inflammation is reduced by 60 to 70% of molecules, which could be potentially hazardous to you. So that also really helps. And then do the LASIK surgery. That really reduces the time of waiting for the patient.
Okay. Anything more from you, Jill?
I do. I think we could be here for a long time, but I know it's late with Dr. Shetty. However, just a few more, please. Sarj Khan, consultant ophthalmologist, says, first of all, please start with a thank you for a most fabulous talk. And that's echoed within lots of chat messages from the participants. Sarj asks, for patients with peripheral neuropathic pain, how long after the onset of pain could identification of specific mediator molecules and implementation of appropriate targeted therapy still be of benefit?
Like I said, the peripheral neuropathic pain, like the neuropathic pain has two components. One is the central component and the peripheral component. Even though it is very difficult and there are not many centers working on the confocal microscopy, but I still feel a classic way to diagnose them is to get a confocal wherever you can send them to, because you will really make your diagnosis very good. Because if you feel that the cornea has nerves are abnormal, that means there is no way you can be treating with the gabapentin or any other drugs. A lot of neuropathic pain, if you have a microneuroma or a lot of dendritic cells, if your drugs are not working, then like Samer said, you can give them autologous serum. But whatever you do, you have to see what you're doing. And if you have a microneuromas, I have tried with taking care by 3 to 4 times spacing, every 4 months gap of a lippy flow with an autologous serum. It also worked. So at this point of time, availability or non-availability is a different issue, but I think this should be a standard of care to at least get one recording, like how you would do a topography before you get into any refractive procedure. There is a role for autologous serum definitely in them.
Thank you. Okay, so Dr. Pretty, we have 2 questions here. The first is there any opportunity to get a copy of your dry eye questionnaire that you ask in clinic? And the second is, how does vitamin B12 affect dry eye?
the questionnaire is, I think, the ocular surface disease index scoring. I think it's freely available. If you don't have it, just ask me. I can send it across to you. The second is we did publish, I can send you that paper also about how vitamin B12 changes. Again, there are a lot of neurotropic factors it works on. We have to understand that as ophthalmologists, we've ignored vitamins completely. And we have completely looked at only vitamin A for the retina, but there are so many other things which play a very important neurotropic role. I think it works through more of a neurotropic role.
Yeah. For the questionnaire, I think maybe they're referring to a slide where you put extra question to OSDI. And I would say what I adopt my clinic is the OSDI, we just expand it. We add our own questions, including question about the diet, because I think as you really nicely demonstrate in the talk, is a role of the diet, especially the vegan diet. This is something I can observe it more and more. And I have to say, I worked also with some other functional medicine doctors who helped me to help those patients to get their body balance again, right? Okay, back to you, Jill.
Okay, thank you. I won't keep you too much longer, sorry. Osama Jaladi's on with us over from the UAE. And Oz says, when to use, excuse my pronunciation, lifitegrast instead of or with cyclosporin?
It's a fantastic question. I personally don't have an experience on lifitegrast at this point of time. But what I feel is the mechanism of action of cyclosporin and lifitegrast is completely different. It works on T-cell mediated immunity and immune cells, and it is more of ICAMP1 receptors. And cyclosporin is MMP9 and more of those IL-2 receptors. So what is important here is they are two different molecules. They're immunomodulators, yes, but they're not the same. So that's why many patients don't respond to one and they may respond to the other one. But at this point of time, lifitegrast may have a good role when there is a lot of pain and irritation in the eyes along with dryness, because these are the pathways mediated by the T cells. And cyclosporin may work more in patients who may not have too much of symptoms, but more of signs. For example, he may have a very low T-but, loss of meibomian glands, and these kind. At this point of time, I'm just giving a hypothesis, but that's how, looking at the molecular pathway, this is exactly what I would do if I had to use both of them.
Okay, good. Any more, Jill?
I could go on forever. I'd just like to say that in the webinars that I've been involved with personally over the last few weeks, I've never had so many chat messages just saying thank you. One that particularly stands out to me is from Martin Robinson, who's joined from Hobart, Australia, where it's 2 a.m. in the morning, and just said he's waited such a long time to hear you, Rohit, and to see your lecture, and to thank you very much. Everybody wants a recording of it, even though they've already seen it once already. Just a late question, please, if you don't mind. Nicolina over from...
No problem.
Thank you. Nicolina over in Ireland says that they're interested in your experience with IPL in dry eye.
I have, we did a cohort of patients, we're just writing this up, of IPL. And I worked with IPL, I worked with a lot of these companies, a lot of these machines. What is happening here is that all these companies, all this thing drops down your cytokines, which actually causes you to have a pro-nociception. What I said, pro-nociception is ones where you make them feel that you are feeling something in your eyes. You have a heightened level of nociception. These patients are, when you have patients coming to your clinic and you can't find anything wrong with their eyes, but they feel that there's always something there, these IPL really helps because these drop down those molecules drastically. So, but what happens is many times as doctors, we say, well, I don't see any improvement in your T-but or anything. It's the same. Yes, it's not going to change. It's not going to pump in more tears, but it is going to reduce the inflammation, which makes you feel better. So making you feel better means your cytokines, which are actually pro-nociceptive cytokines, have drastically dropped. And trust me, at this point of time, this works beautifully well. So if a patient has signs, but no symptom, patient has symptoms, but no signs, IPL works. When you have symptoms and signs, then your drugs and IPL works.
Amazing. Thank you. So before I hand over to Samer to close, again, Dr. Shetty, I can't tell you how many messages. Yeah, and I'm going to pass over to you. How many messages have come through? For anybody asking questions still, I will email them over to Prof and get an answer. Please don't feel I've left you out. Yeah, it's unbelievable. How many people have just said amazing in the last half an hour is quite unbelievable. What I would like to do before I give Samer back the floor and ask his final question is just to let everybody know before they sign off, because they're asking when the next webinars are with OSI. So we have an extra one next week with Francesco Coronis from Italy, who's going to be talking about the lockdown and how it's ended in Italy and what they're doing with ophthalmology moving forward. So that's next Wednesday. And then following that, we have Raman Malhotra with an oculoplastic surgery and assessment in ocular surface disease webinar. And then following that in June, the future of vision correction for keratoconus. So lots going on within the OSI for those people who've stayed on and asked that question. Thank you for asking. I will continue to send you those details. I'm going to say thank you so much again to Rohit on behalf of all the participants. And I will hand over to Samer to ask his questions and close the webinar. Thank you.
Right. Thank you, Jill. Right. Just maybe one final question, because I've been asked this question. My mobile just got a text insisting that I ask you before you go. It's about neuropathic pain. I mean, it's a bit of really a struggle to treat those patients with pain no stain, and I think the modality treatment is very limited, as we know. Some patients here go to pain management clinic and they get migraine treatment. What's your experience? Because I mean, you have the privilege, as you can see, you have the microscope, confocal microscope to look inside the cornea. But for the average cornea dry eye specialist, what's your advice?
For a lot of neuropathic pain, if you don't have this exam, still I would advise that if your patient is suffering, just get one done wherever the patient had to go. That is something which I still stand by. But one thing really helps me to differentiate the peripheral versus central is if you put a drop of Paracaine on the patient, and if your pain reduces, then you know that it is more of a local problem than a central issue. Mm-hmm. So then what I do is then I put a drop of Paracaine and give them time, and the patient feels that he's better. Then I know then I see if he's been given sometimes patients get steroids for 1 week, 10 days, all that doesn't work. Neuropathic pain, if it's a peripherally sensitized neuropathic pain, then you have to give them for at least 2 or 3 months time. The patient has to be looked for, I usually look for vitamin D, B12 deficiencies in them because a lot of neuropathic factors. I give a trial of, if I have an access, give a trial of cyclosporin with steroids for 2 months of steroid and 6 months of cyclosporin. And I call the patient after 6 weeks to 8 weeks, that means 2 months, and I ask them how they are feeling. If they're feeling not good, but I still believe that it is a peripheral, not a central one, then I give them a trial of scleral contact lenses. Mm-hmm. And this also works. And if the patients are educated and they are able to maintain it well, I even sometimes give them an option of autologous serum like you do. Mm-hmm. But most of the patients I have treated, if you are aggressive with your management of steroids, with cyclosporin, with your vitamin Ds, B12s, and all these factors, there are times I even give them oral probiotics, because gut microbiome changes have a huge implication in ocular inflammation. So probiotics also has helped in many of my patients because it changes the gut microbiome. And if the patients still feel after 3 months, even with the contact lenses, even with if I give a scleral contact lenses, they're still having a pain, then I refer them to a headache clinic, and then the people start on gabapentin and other drugs. But my major challenge is these drugs make you drowsy. It's not a pleasant drug. It's not the drug which I would like to give my patients. So before you send them to a higher place for a headache or anything, at least give them for 3 or 4 months of your trial. I think 60 to 70% of them get better with your aggressive steroids, with cyclosporin. Some of them get better with your Lipiflow or iLight or IPL. And the 20% of them who don't get better then go into contact lenses or autologous serum based on their affordability and education we can try. And those who 10% of them or 5% of them who actually don't get better, they they are the ones I would refer to a neurological clinic.
That's amazing, amazing. Rohit, thank you so much. I think we could invite you again because it's just endless questions and stuff. But I'm really, really grateful for you coming today to this webinar. I think you enrich us with a lot of information and knowledge from your experience. And you summarized years of experience and research in a very elegant talk on 30, 40 minutes. It's amazing. Thank you so much. And the feedback so far is overwhelming how good it was. And I think they want me to invite you again, which I will. Okay. So thank you very much. I just want to thank you, Rohit. I just want to talk about, say about OSI magazine and the webinars. We'll continue, as Jill said, we have kind of few future coming webinars. One of them, just to highlight the management of vision improvement, how to improve vision in patients with keratoconus. That's going to be on the 11th of June. We have 6 international speakers. It's going to be really, really worth your attending and contribute with questions and get your answers. So just to the magazine itself, we still welcome your contributions. You know, it's quarterly magazine, and any interesting topic related to the ocular surface or cornea, please send to us and we'll look into it and help you publish it as long as it's help the readers. So I'd like to just to conclude now, thank everyone for staying to the end. Thank the OSI team, thanks Jill, also Denise, great work behind the scene. They really make this, it's a lot of work. It's not just about going live and that's it. It's a lot behind the scene. So thank you, the team. Thank you again, Rohit. It's amazing. And hope to all see you again. So the next webinar is on the 20th of May. That will be with Francesco Caronos. He will really help us to tell us, share his experience, how to reopen the clinics after the COVID now, which they've already started, I think last week or 2 weeks ago. So good to learn from him. And there's a lot of other webinars which Jill just mentioned. Thank you all, and hopefully to see you next time.
Thank you.
Thank you.
Thank you.
I want to nothing at home.
Are you still there, Denise?
I am.
I'm typing all the questions. We've still got 14 participants on. I'm not sure if they don't realize they've not ended the call, but if I end the call, I can't see the questions, and there are loads. So I'm just trying to capture each one.
No, it's been a great webinar.
So yeah, I'm wondering if there's still people hanging on because they feel maybe I could answer the questions now, but I can't get to them all. But
See Harminder do is trying to unmute himself.
Hi, Harminder. Okay. What I'm going to do, I'm going to end the call for everybody. Now I think I've captured all the questions, and then we'll maybe speak separately. Hi, Sarge.
Yeah, okay. Well, you get home and get sorted. Why don't we catch up tomorrow?
No problem. Will do.
All right. What time's good for you now? I know you're busy from 10:30. Is it best before or after?
It's all a blur at the moment, so just give us a buzz when you're ready.
All right. I'll do it early on then, because we've got a team Zoom at 12. We'll probably be on for an hour and a half. So, and then it's running.
Problem.
Well, it'll only be quick. We'll just have a quick catch up in the morning, and thanks for those through as well. So, and in the end, he came good.
He did.
Yeah.
Okay, I'll get off the call. Thanks a lot.
All right, my love. Bye. Bye.